I went to that car wash by the ice cream place, In-N-Out. It's pretty good. I mean, it's expensive.
There's an In-N-Out here?
No.
That In-N-Out.
In-N-Out.
Yeah, In-N-Out. That would be awesome.
But it was good. They actually like vacuumed the inside of your car.
It's alright, we still have Krispy Kreme for now.
All right.
All my Krispy Kremes. Chick-fil-A does for breakfast. Krispy Kreme is supposed to be closed.
I think we're good. I think this is it.
That's not
They make cheese donuts. Chili cheese donuts.
Donuts on the inside. They make donut burgers at the same fair.
I'm not.
Yeah, we're going right now.
Yeah, we're recording. I was just waiting for one. I was waiting for one of you guys to say something funny, and then I could be like, "Oh yeah, that was J-Red." All right, so I'm giving a talk on anesthesia for cardiovascular surgery. This is a large topic, so I hope by the end you don't feel like this guy. I'm going to try to concentrate on things that will like get you through your clinical day-to-day stuff, as well as highlight some things that you'll see on your boards, and focus on things that will allow you to provide a safe cardiac anesthetic no matter who you run into. So objectives: understand the various parts as well as consequences of cardiopulmonary bypass. Understand and review the steps for safely going on pump and coming off pump. And there's a handout that you shouldn't look at necessarily yet, but it'll be something you can refer to after the lecture is over for sort of basic steps for any pump case, going on, coming off, and how things are kind of broken down. And then lastly, again, sort of highlight some high-yield information for day-to-day life and for exams. So we're going to start by looking at first the pump, which has 5 basic parts, but the overall construction of the cardiopulmonary bypass pump is to basically do what the heart and the lungs do for the normal person. So the pump is going to not only deliver oxygen-rich blood to the body, but it's going to filter through it deoxygenated blood, so it's going to act like the lungs in that capacity. The 5 basic parts that comprise the pump: number 1 is circuit tubing. You may ask, well, of course it's got tubing, why do we care about that? The second one's reservoir. We'll get to each part. I want to go through all 5 of them first. So circuit tubing, reservoir, oxygenator, heat exchanger, and then the main pump and filter. So for the circuit tubing, the reason that you care about this to some degree is because it's always primed volume beforehand. Depending on if it's a pediatric patient or an adult patient, may vary what exactly they use to prime the pump with. For adults, they usually prime it with crystalloid. So what that means is your patient, the minute they go on pump, are going to get a bolus of around a liter and a half of fluid, unless you do some other things to try to modify that. Some pediatric patients, they'll prime the pump with blood because you can't afford to give that much volume to a pediatric patient without causing major disturbances. So in the case of an adult, the major consequence of that is you're going to have human dilution. So one of your tasks is to try to limit some of the unnecessary crystalloid that you see pre-induction. So try to be somewhat mindful of, once you induce, not letting your attending leaving the fluid running and running in the entire bag. So you check behind them, not let them do that. So in addition to adding the volume, you're going to get a drop in your crit. You're going to dilute your coagulation factors and your proteins, and there's going to be a dilution in the concentration in whatever anesthetic medications or opioids that you've given up until that point. So it's a time of dynamic change. One of the things you can try to do to try to prevent that is something called a RAP. Has anybody heard of that before or know what that means? Yes, that's exactly right. So a RAP is a retrograde autologous prime. And what that does is once they cannulate the aorta, what they'll do is they'll say, hey, we're going to RAP. The perfusionist will allow some of the blood in the aorta to back bleed into the arterial cannula to basically wash off some of the crystalloid and fill up that residual tubing with blood that was originally in the patient. And that way you don't get quite as much hemodilution as you otherwise would. Now, what would you expect would happen if you start doing that? You're going to get hypotensive because you're basically exsanguinating the patient. Whatever volume of blood that you can fill into that tubing leading up to there, so 300, 400 cc's. So if you hear them say, hey, we're going to RAP, just let that key you in that something's about to change. And you may have to treat the blood pressure at least until you get on pump. All right, so then the reservoir. So here's a picture of the reservoir. That's where all the deoxygenated blood is going to be dumping into. You'll notice that so it all flows by gravity. Most of the machines actually have a suction device applied to it so it assists some of the blood coming out. But there's a little monitor right there, and if the blood level falls below that, it starts going nuts. So it starts beeping and alarming. And that's to let the perfusionist know that, hey, they're losing volume somewhere. And if we critically deplete the entire volume in the reservoir, you can get an airlock. So you can get an airlock in the oxygenator, and that's a problem. So you could potentially start sucking air, getting it going through the pump, and then you would deliver an air embolus to the patient, which could kill the patient. So that's a critical alarm. So if you ever, I mean, they're all over that, but if you ever hear that going off, they got to do something about that. Either they've got to figure out, they've got to slow the amount of blood that's coming into the reservoir so that it builds back up, or they've got to add some volume directly into the reservoir. It's usually what they do. That's the quickest, easiest way. They've got, usually crystalloid blood wide into the reservoir, and they can just open it up and dump it in. And then you need to search for, if the volume's not coming back in the reservoir, where's it going? Okay, and then oxygenator. So it's hard to see on this part right here, but the oxygenator sits directly underneath the reservoir. There's all kinds of different oxygenators. In the past, they used to use bubble oxygenators, which used to actually physically give a bubble and oxygen into it. But most of the new oxygenators are membrane oxygenators, so oxygen diffuses in by diffusion, and then the CO2 is drawn off. They're a little bit more expensive, but over time they've been able to develop less expensive ones. So almost all the oxygenators you're going to see are membrane oxygenators. These are the things that if you're not adequately heparinized, they'll clot off, and that's a problem. I've actually only seen one that happen once, but it turns into like a really kind of intense thing to try to change out one of these mid-pump. So essentially you would have to shut off the pump and clamp on either side and then try to reaffix a new one in and then reattach one. It's not something that you want to happen. So, but that's the part that is sort of at most risk for clotting off when you're on pump. Again, you can add oxygen into this. You can also add volatile. So when you go on pump, the perfusionist actually turns on isoflurane and keeps the patient anesthetized, even though you're turning this off, and it's doing it through that area of the machinery. There's a heat exchanger, so that's usually on the end of the oxygenator, and there's just warm or cold fluid running around the outside of where the blood is going, so you can either heat the patient or cool the patient. So it heats or cools the blood as it goes through there, and then it'll return to the patient. You can do either one to the patient as it comes back to them. And that works by conduction. And then finally, you've got the main pump and filter. Modern pumps are usually roller heads. So the tubing is actually outlaid inside the pump, and then the pump actually rolls the blood along, versus a centrifugal pump, which were the old pumps, where they actually had little like propellers inside, and it would like whisk the blood along, but that caused more red cell damage, and they figured out that this was less damaging to the red cells. There's one main pump head, and then the other roller heads can be used for different things like suctioning or cardioplegia delivery, or different types of venting systems that they're going to potentially put in the heart. And then there's a filter on the end of the arterial side that's supposed to remove any debris or anything that's getting sucked back into the reservoir or to any of the lower heads, because you don't want to be delivering, emboli to the patient. So here's just a video of going on pump, and just try to pay attention to a couple different things that the perfusionist does as they go on pump. So there's a clamp, that's important. So she turns on a little oxygen, she sets the timer, we're starting. She takes the clamp off, and that effectively initiates going on bypass. So now the blood starts flowing. The deoxygenated blood from the patient starts flowing out of the reservoir. And you'll see the reservoir, the fluid level rising. That's the main roller head pump that's starting to move blood to the patient. And she's tapping air out of near the filter so that the patient doesn't get any air. So that's great, but there are consequences for putting a patient on bypass. So you get a huge, massive release of catecholamines, cortisol, vasopressin, angiotensin, and a lot of cytokines. You activate complement, so you get different amounts of coagulation and fibrinolysis that gets initiated. you wipe off the glycoprotein receptors off most of your platelets, so your platelets become dysfunctional. And the overarching results are going to get coagulation abnormalities and electrolyte disturbances. There's going to be things that you can do to try to correct some of those problems that we'll talk about later. So now on to sort of more like so that was just sort of an overview of the pump, and now we're going to kind of talk about sort of, you got your first cardiac patient, so you're going to go in there, and the things you need to sort of be thinking about pre-induction when I'm going to go to pre-opum. So we'll break that down into information gathering, pre-medications, lines of monitors, and then drugs of choice for induction. So it's important to know the procedure you're doing and the surgeon. The surgeon does matter. You'll learn with experience that if you haven't already, that not every surgeon is necessarily the same in terms of bleeding and time in which they do a certain thing. So that can impact that risk for bleeding that you might see during the case, or the amount of ischemia that you might see at the end with the heart. So prior cardiac procedures also that you might want to pay attention to in particular are, have they had a sternotomy before, or have they had prior grafts? And the reason for that is that they're going to be a higher risk for bleeding. So you want to make sure that you have your blood in the room and have your blood checked if that happens. We typically go with 4 units. So if if it's a reedy chest, the risk is that they're going to use their sternal saw, and that they would cut into either a graft or they would cut into the RV once adhesions have formed, and then you're going to be into a huge mess. So often what they'll do is they'll actually cannulate somewhere else first, either in the groin or in the axilla, so that they actually have somewhere to go on pump. Otherwise, if they can't quite get to it, if they ascend the aorta. So it's important to know what they've had done if it's the first time that they've ever been in the chest. When you review the echo and the cath data, you're going to want to know LV function and EF. That's going to impact how you potentially might induce the patient. It also might impact the pressor selection that you choose at the end of the case. If you've got a patient who's got poor ventricular function going in on bypass, they're likely going to have, it's not going to necessarily be better when you come off after they've been ischemic for 2 hours. So that's the type of patient it's nice to know, hey, we're likely to need epi when you come off. Valvular dysfunction, so left-sided stenoses in general, you're going to want to keep your heart rate relatively slow and your afterload high, whereas regurgitant lesions, you're going to want to keep your heart rate on the relatively higher end of things and keep your afterload near normal but not high. And then RV function and PA pressures, that can impact whether or not you're going to do a PA catheter, as well as whether or not you're going to need pulmonary vasodilators. And then on the cath report, it's important to note the dominance of the coronary circulation, and I'll talk about that in just a little bit. Right dominance versus left dominance. You may see that, and if you don't know what that is, then we're going to go over that. And then the last question asks sort of, do they have a history of dysphagia or esophageal pathology? And that's basically just getting at, we're going to do a TEE, so we need to know if they have a history of stricture or something that would put them at risk for perforating their esophagus. Because not every heart procedure that you do necessarily needs a TEE. And there's higher, an aortic valve or mitral valve, you have a higher need of doing a TEE versus a CABG. The CABG could potentially just do the case with no TE at all. So if they have risk factors for, perforating esophagus, you just potentially just not put in a TE at all. And it's nice lab-wise, platelets, crit, coags, fibrinogen, all things that would give you higher or lower risk of thinking about bleeding afterwards. So to that question of dominance, just a brief review of coronary anatomy. So this is as if you're above the patient. So mitral valve right there on the left. Tricuspid valves there on the right, aortic valves right in the middle, pulmonic valves at the top of the screen. You got your right coronary going around that way, and then your left main splitting and your LED and left circ. If you look at sort of a schematic of the right coronary, you've got conal branches coming off, but the major branch that you should pay attention to is the PDA. And so that's a branch of the RCA that comes around and wraps around the back, and it gives supply to the septum and the inferior wall of the LV. And that's the important part to note about right versus left dominance. So if a patient is right dominant, which most people are, in fact 85% of people are right dominant, that means that the PEA comes off the RCA. But not every single patient is that. The remaining, about 7.5% are left dominant and they come off the left circumflex. And then the remaining percentage are people who are co-dominant, so they actually get supply to that inferior wall from both the RCA and the left circumflex. Just a quick digression about the left coronary side of things. So You may see on prior reports that they've had a cabbage. If they say, they have a vein graft to OM1 or DIAG1 or DIAG2 or OM2, what that means, if it's a DIAG, it's a branch off of the LAD. And if it's an obtuse marginal branch, it's a branch off the left circumflex. So that's just what that means. And they're numbered in by how soon they come off after the split between the left circ and the LAD. So for example, here's your LAD coming down, and the first branch coming off here is the first DIAG1, and that's DIAG2. There's also a branch not shown there that sometimes comes off right in the middle, and depending on how big it is, you could get a significant infarct if it clotted off, and it's called a ramus. So if you ever hear someone talk about in the cath report a ramus branch, that's typically where it comes off. And it varies in size, and some people don't have one at all. All right, pre-meds. So just consider the patient in the context and use some common sense. So a lot of patients can tolerate a little bit of pre-medication, but if your patient has significant right heart pressures and PA pressures and they're not that anxious, you wouldn't necessarily want to pre-medicate them heavily in the pre-op area because you could have them raise their CO2 and then they could arrest. So that's not good. So be more conservative here in pre-op for some of the patients who are older and potentially really frail. So lines and monitors, we typically place most of our A-lines awake or judiciously sedated in the OR. Most of the time you're going to place them in the radial artery. If the patient has fistulas on both sides or for some other reason you can't use a radial, you can always use a femoral as a backup. Things to consider, occasionally, you won't run into it very often, but they will do a cabbage with an arterial graft. It's poor form to put your A-line in the side that they're planning on taking out. So if they're doing a cabbage, just try to check and make sure they're not doing an arterial graft. They tend to take the arterial graft they're going to do for their surgery from the non-dominant hand. So guys right-handed, they'll take their graft from the left hand. But coincidentally is often where we end up putting our A-lines. So it's just something to double check and make sure you're not doing. And then this can get a little confusing, but there are certain aortic surgery procedures, and we do quite a bit of those here, particularly for some ascending and for arch work. You'll end up needing two A-lines. So you'll put one A-line in awake before you induce, and then you'll put another A-line in on the other side once you're under anesthesia. And the reason that you do that is so that the left radial will monitor systemic perfusion throughout the whole case, and then the right radial will end up monitoring antegrade cerebral perfusion, which is something that they do to try to protect the brain during any kind of procedure where they might have to do circulatory arrest. So why would they do that? So here's kind of a schematic of that. So this is a diagram of an aorta that's got an ascending aneurysm, and it extends far enough up toward the innominate. So here's your ascending innominate, left common carotid, left subclavian. So it extends far enough up that it would be hard for them to get a clamp and graft here and continue to maintain perfusion to the whole body as well as here. So what they end up having to do is they cool the patient and they basically stop all blood flow long enough so they can attach a graft to the proximal end. Or they do a hemiarch where they cut off part of this, attach a graft here, and then extend the graft this way, clamp on the graft, and then return circulation. But if there's not enough room to clamp here, what they'll do is they'll cannulate the axillary artery here, and then they'll end up clamping the innominate as they sew in, and the axillary artery will start receiving cool blood this way, which will go to the brain. And so that will try to also deliver some oxygen to the brain while you've stopped all blood flow. Because you can imagine if you stop all blood flow, even if you've cooled the patient, eventually you're going to start getting a massive brain injury. Because it turns out that cutoff is somewhere around 20 to 30 minutes before you start, forgetting who your second cousin is. And so they try to figure out things that you can do to try to limit that. So clamp time is by far and away the most important thing. Then temperature, and then finally whether or not you do antegrade cerebral perfusion, which for anything that they're going to start thinking about those times being longer, they're going to start considering doing that. So that would be the reason that you would do right and left. So the left will monitor systemic always, and the right will monitor, when this starts happening, will monitor how much pressure is on that side. Because you don't want that to be too high either, otherwise it will cause brain injury from too high of pressure perfusing during that time period. Does that make sense? And so at the end of the day, that's what they end up doing when they do a hemiarch. All right. So usually you're also going to do a central line. It's a tinning preference. You'll see some folks will do triple lumens for a lot. Some will do cortices for almost everyone if they, you know, so you will see some variability there, but almost everyone's going to get a central line. You're going to put most of those in post-induction, ultrasound guided right IJs. You can do a left IJ if you need to, or a left subclavian if the right IJ is clotted. I tend to put the TE probe in first before you prep to do that, just so that when you put the wire in, there's no question. If I have the TE probe in, I can see the wire go under the right atrium, and then I know that you've cannulated the venous system, and we're not worried that you've backed-walled it or gone through and through, and then now you're in the aorta, or it's going down the arm, and there's no question. So that's why, if you see me doing it, that's why I'm doing that. And then a PA catheter, so if you work with Dr. Kratz, he'll put in the PA catheter for every single patient. But there's decent evidence now that you don't necessarily need a PA catheter for everything. What the PA catheter can tell you is it can tell you PA pressures, it can tell you a wedge pressure, which is going to be a surrogate for your left ventricular end diastolic pressure. If you've got a continuous cardiac output PA catheter, which we have, it'll give you a cardiac output, and then it'll give you a mixed venous oxygen tension. But there's really nothing in real time that a PA catheter can tell you that a TE can't. So really, if you're putting in a PA catheter, ideally, you're really doing it for post-op management when the TE is not going to be sitting. So I tend to put in a PA cath if there's poor LV function, if there's evidence of right heart failure, or evidence of pulmonary hypertension, which are all things that you would have a hard time telling in the unit afterwards if you didn't have in place.
You usually do the right IJ just because there's less complications on the left IJ.
Yeah. And if you are going to do a swan, I will say just from experience, it's a lot easier to float a swan from the right than from the left. You get the swan like going down the arm, or you get it running past and going the wrong direction. It's just can be really painful. So a little bit of a digression, not to be anti-Kratz, but there are multiple studies that show that there's, in terms of improving outcome, that there may not be benefit in the critically ill population. Now, obviously, this is a different population as cardiac surgical patients, but given some of these studies that were in the New England Journal and JAMA, the overall usage of PA catheters across the board has decreased. And they're not as if they're not without risk. So it can lead to misguided management. So if your tip's not in zone 3 of the lung, which is the place where your arterial pressure should exceed venous pressure, which should exceed alveolar pressure. So you should get a theoretical continuous column of blood from the left atrium through the lung to where your PA catheter is sitting. So if your tip's not sitting where it should be, then you could be getting an erroneous reading and then making decisions based off data that's nonsense. When you're floating a catheter, you can get sustained VT. So if your patient has, the other one's heart block. So if your patient has a left bundle branch block and you float a catheter and you put them in the right block, and they go into complete heart block. I've seen that happen multiple times. That's a problem. Oftentimes you can just pull the catheter back and it stops. But occasionally it doesn't. And so that can be a problem. And then the biggest risk is pulmonary artery rupture, which only happens about 1 out of 2,000 times. But when you consider that when this happens, mortality is about 50%, that means you would kill about 1 every 1,000 people that you put in. So just think about it. It's not as benign of a procedure as it seems like. All right, TE. So practice guidelines for who gets a TE. So all open heart procedures, you should consider it. Should be considered in all CABG, but as I told you earlier, it's not an absolute requirement. Catheter-based intracardiac procedures, so that's like TAVRs or MitraClips. And then in certain non-cardiac procedures like lung transplants or liver transplants. The absolute contraindications to a TE, so an esophageal stricture that hasn't been corrected, tracheoesophageal fistula, if they've had recent esophageal surgery or esophageal trauma. So those are only absolute contraindications to doing TE. Other stuff like, they've had gastric banding or they've had a Roux-en-Y or something like that. Then I think you have to consider the risk-benefit depending on what surgery they're doing and whether or not you want to risk, popping that band open. Or, in the case of a mitral valve, for example, I might be inclined to do it. But in the case of an aortic valve, I may say no and say, you know what, if we can actually look at the aortic valve with an epicardial, I can throw you an ultrasound probe and we can put it on directly on the heart and look at the aortic valve. Whereas a mitral, you can't. So mitral would maybe hedge more on the side of doing it in that scenario. So unless you have one of these absolute contraindications, it sort of becomes a risk-benefit analysis. All right, a couple words about TE. So there are 20 standard views. There are 3 viewing windows. There's the upper esophagus, mid esophagus, and then transgastric. So those are the 3 depths that you can be at. Those are the 20 views. Most of them, actually the majority of them, will reside in the mid esophagus. And 6 of the views are actually, 6 of the views are the aorta, and the rest are the heart. You're not going to remember it from seeing all this, but I just wanted to show you that there are 20 of them. And then if you're more interested in, yes, nice. If you're interested in looking up more about TE, you can go, if you just Google Toronto Echo, there's a great website that has a simulator, and basically it gives you a picture of where the echo probe is, how it's cutting, and then how it's generating that image. I think this was like the best thing that I used when I was getting started to try to figure out orientation. And now the only question I got about the echo exam, only question I got about echo on the written boards was the following question, and it was, which TE view best evaluates coronary blood flow from all major coronary distributions? And I've heard it is asked multiple different ways. So they may ask it, which is the best for detecting ischemia, or which is the best for detecting regional wall motion abnormalities? And so the answer to that question is that. So if you don't remember anything from today, remember that, because they'll ask it in some form or another on your written boards. So it's transgastric, so you advance the probe all the way into the stomach. It's mid-papillary because you're cutting the LV at the level of the papillary muscles, and it's short axis because it's short axis. So I'm going to play that for you. So that's a picture of an LV shortly coming off bypass after doing an aortic hemiarch repair. The wall motion looks fantastic. The LV is empty because we've just come off bypass. The contractility is great. And we're able to look at all the different wall motions. And so on this next slide, it's going to break it down as to which coronary artery is perfusing which segment, or which segments of the LV. So in the case where the little red boxes are, that's the anterior wall. It's farthest from the probe. It's the front of the heart. So it's the anterior wall. Anterior and anterior septal wall are perfused by the LED. The green boxes are the inferior and inferior septal wall, and that's perfused by the, I skipped one, the PDA, which again in 85% of the people is going to be your RCA. And then the yellow ones are your left circumflex, so inferior lateral and anterior lateral, the side of the heart. That's going to be your left circ. So this is the only view that allows you to see all 3. You take the next slide. This is someone who has global poor LV function. So compared to the last one that you saw, you can tell this LV is dilated. None of the walls are moving especially well. The words you use to describe this are akinesis, dyskinesis, or hypokinesis. Hypokinesis just means it's less than it should be. Akinesis means it's not moving at all, and dyskinesis means it's moving the wrong way. In this case, it looks like if we were to break all those segments down, everything is at least hypokinetic, and I would say the inferior septal and anterior septal walls are almost akinetic. The anterior wall is hypokinetic, more so than the anterolateral and inferior lateral walls. And then in real time, sort of real life application, how can this help you? Well, this was a patient who was having an orthopedic procedure. They'd been brought in after a trauma. I think it was a car wreck, or maybe they fell. But it was an older person they didn't have a whole lot of history on. She became hypotensive in the OR. They called for an emergency echo. We popped in an echo. Does anybody, if you, given what I just showed you, is there anything about that heart that looks abnormal? Yes. So we put the probe in and we saw some MAR, and then we also saw that there was inferior septal and inferior wall hypokinesis, and we're like, huh, that's really odd. And then we did some more prying, and we figured out that she'd actually had a CABG before. So she got sent to the cath lab, and it turned out she had a 3-vessel CABG, and she had her PDA graft due to the PDA graft was down. So then they went in and fixed that. So it does help. It can help you with pinpointing the diagnosis and what's going on. All right, so we're going to transition a little bit. Patients who will try to die on induction. Anybody can try to die on induction, but there are a subset of people who notoriously, if you just come in and you push 220 of propofol and 100 of subs, you could potentially kill them. So one of those people is left main coronary disease and notorious for having arrhythmias, or if they become too hypotensive and they try to cramp on you. Severe RV failure, same thing, not well tolerated, you just push a whole lot of propofol. Put LV failure in parentheses, but I almost feel like severe RV failure is much harder to deal with than LV failure. RV failure is a problem because if it's a preload problem, you can try to give a lot of volume, but if you give volume too fast, then the RV fails. Versus the LV, which has a little bit more of a buffer than the RV. Severe pulmonary hypertension for a lot of the same reasons that RV failure is a problem. Severe mitral stenosis, so they're really preload dependent, and they don't tolerate tachycardia very well at all either. And then of course tamponade. So induction. So the short answer is there's no one right answer, and you're going to run into attendings who are going to induce a myriad of different ways. But I will say, contrary to an older teaching style from 15, 20 years ago, you can use propofol for most patients as long as you just use it judiciously and you titrate it in slowly and you give back what you take away. So if you're going to take away afterload, just give some afterload back. So if you mix in some phenylephrine as you go, a lot of the time you can kind of nurse them through induction. That's fine. The older ways used to be very heavy weighted on benzos and opioids, and I would say a lot of the time we still tend to give a little bit higher at the beginning of benzos and opioids to avoid having to give big slugs of propofol when we induce. The downsides of giving, when I say big doses of opioids, I mean they used to come in and push like 100 milligrams of morphine, like push, and that was the entire anesthetic. That's okay, except that's why they had high degrees of awareness because that did nothing for amnesia, and then they wouldn't actually start breathing on their own for like a week later. So there is certainly a happy medium somewhere between pushing 200 of propofol and pushing 100 milligrams of morphine. So the risks of doing heavy benzos and opioids are delirium in the ICU, prolonged wake-ups, and for really high doses of, say, like fentanyl, you can get chest wall rigidity. Has anybody seen chest wall rigidity yet? From pushing a lot of either Remy or fentanyl. But it's not, at higher doses, it's not that uncommon. You probably just haven't seen it because you haven't had the need or want to give like 800 fentanyl push. But that's one of the reasons why you wouldn't necessarily do that. And then etomidate. So that's always a question that's a little bit controversial. So the primary risk with using etomidate to induce for, say, everyone is that you're going to get cortisol synthesis, suppression, and then there's a question about whether or not that actually affects mortality or affects vasoplegia when you go on pump. So there's an article from ANA at the bottom that talked about anesthesia induction with etomidate rather than propofol was associated with 30-day mortality. The problem is that the study was retrospective, and so of course the patients who got induced with etomidate did worse because they were also the sickest patients to begin with. They got etomidate because they were sick. But with that being said, there are some other studies, that ICU studies that say you don't do a continuous etomidate infusion because that's associated with increased mortality. Is a single dose induction dose of etomidate associated with increased mortality in cardiac surgery? I would say it's controversial, and I don't know the answer. Given that I think it's probably okay, but that there is this sort of controversial aspect to it, I tend to not give it because I can do it other ways safely that are not controversial. With the exceptions that I think, emergencies. So if you've got a patient who is not NPO and you've got to do an RSI, etomidate sucks. It's great. It'll be stable. You're not going to bottom them out. You can still get some sympatholysis with etomidate as well, even though it's a cardiac stable induction. I don't know if you've ever pushed etomidate in someone who's dying and watched them crump as you pushed it. But you can get a little bit of hypotension from it as well. So if you need to do an RSI, or if you have someone who's maybe still conscious but they're actively trying to crump on you, then in that case, yeah, sure, give etomidate. Let's see. That was one that actually said it the other way. So the Komatsu was the one saying it was bad, and then Wagner was the one that said it's not bad. There's no difference. So maintenance. So you'll see most commonly people use isoflurane, an inhalation agent, which actually has, not only is it cheaper because you're going to be on, it's an anesthetic that lasts longer, so it makes sense to use ISO. There's actually decent evidence that ISO actually attenuates ischemic reperfusion injury. So I tend to turn on a little bit of ISO when we're about to come off pump. I'll turn on a little bit before we, as we're like reperfusing the heart, to try to attenuate that ischemic perfusion injury. And there's some interesting articles about dexmedetomidine. It's more expensive, but at some point it's going to come off patent, and I'll be interested to see how that plays out. But there were a couple articles recently, actually, one in Circulation and the other one in the Red Journal, talking about patients who, once they were put on dexmedetomidine, once they went on bypass, and actually had improved outcomes. So they had decreased delirium and decreased lung mortality. So just something to think about. In the past, I feel like I've only tended to give dex for people who had some other reason. They were like chronic pain, or they were had opioid addiction, or alcoholism, or some other reason to necessitate that. But I thought this was kind of an interesting thought that there may be some other added benefit to it that's not just sort of psychological or substance dependence related. Okay, so steps before going on pump. The first sort of major portion is you're going to anticoagulate the patient to get them ready to go on pump. Then they're going to cannulate the arterial side. They're going to do the arterial side first, because if any problems happen at that point, they've already started to get the biggest access you could possibly have, versus doing venous. If you start the venous side first and you start screwing up, then it's not as awesome to like try to pump 3 liters a minute to the venous side. It's much better to do it on the arterial side. So they do the arterial side first. Then you're going to go on pump, and then you're going to arrest the heart depending on the procedure, so they can actually operate on whatever it is they need to operate on. And note that going on bypass has nothing to do with the actual electrical activity of the heart. So you can go on pump and be sitting there with the heart beating the whole time. Only once you give solution to stop the heart does the heart stop beating. So those are separate processes. So anticoagulation, a lot of places, or the book will tell you, you can use a weight-based strategy, so you can give anywhere between 200 and 400 units per kilogram. I think the standard book answer is like 300 units per kilogram. And then check an ACT afterwards. So that's a weight-based strategy. A little digression about that. Well, what is a safe ACT for bypass? So the book answer, and Morgan and McHale, I think, say 400 seconds. But I will say that I've been at the 3 different institutions I've been at. There's different, depending on the surgeon, depending on the institution, there can be different levels that are safe for bypass. The most I've seen is 480, 450 seems to be around the middle, and then 350 is the least I've seen. The original study from 1975 that did the study in dogs that looked at what was safe, they didn't have any oxygenators cut off for ACTs that were greater than 300. So they arbitrarily picked 480 because they thought that 180 seconds above that seems like a reasonable amount in safety zone. What's funny is that I think a lot of folks after that interpreted that to mean that 480 is what you needed to be minimally safe for bypass. So there are still some institutions that will ask that you have an ACT of 480 to go on pump, but I think that's highly unnecessary. The reason I think it's a little unnecessary is that in order to achieve an ACT of 480, you're going to have to give more heparin than you otherwise would have. Heparin gets sequestered in endothelial cells. It rushes back out about 2 to 3, 4 hours later. So when the patient's sitting in the post-op area or in the ICU and it all rushes back out and you start bleeding again, then you're going to wish you hadn't given all the extra heparin. Just something to think about. According to current studies, there's no apparent advantage to maintaining ACTs below 400, however. So 400 tends to be the answer that you see. And if you ask on oral boards, it's a safe answer to give. If you say 480, they're going to ask you why so high. The way that we do it here, we use a HepCon system. So they take a sample of blood. It goes into different wells. It has different wells with different concentrations of heparin, and then it actually is going to plot the ACT based on the different concentrations. And it's going to assume that it's a linear relationship. And so then they're going to be able to calculate a dose for you and tell you, hey, if you want an ACT of 400, then give this much heparin. So it's nice. So you come on the board, you'll notice the perfusionist will write on the whiteboard, heparin dose for bypass is 24,000 units. Likewise, they can also calculate the amount of protamine you have to give at the end, so you're not just willy-nilly giving a ton of protamine and not knowing how much you need to actually neutralize what you've already given. And that's just a picture of one of the HepCon machines. All right, antifibrinolytics. I'm going to glaze over this a little bit, but there's an old antifibrinolytic, aprotenin, that they used to use that we don't use anymore because they had a black box warning that came out in 2007 because there was association with increased mortality, anaphylaxis, kidney toxicity, graft failure, and those problems they did not see with some of the more newer ones like Amicar and TXA. So these are all lysine analogs. They prevent conversion of plasminogen to plasmin. So they work at that branch point. And so if you inhibit plasminogen to plasmin conversion, then you stabilize clot and fibrinogen doesn't break down. They like testing this on boards for some reason. But just remember that it's a lysine analog and that it works there. All right, cannulation. So the three primary parts for cannulating the arterial side, ascending aorta is sort of standard. Axillary artery, we potentially do that in redo surgery, or if they're going to do an ascending aortic surgery like we talked about earlier. And then femoral is sort of reserved for emergency situations or situations where you can't cannulate these other two sites. The downside of doing femoral cannulation is that if you can imagine, the aorta is used to blood flow going one way, and most of our patients have even a lot of Bojangles, so they've got lots of atherosclerosis. It's used to blood flow going that way. Now you start shooting it back up the other way. Probably not the best thing to do for most of those patients. On the venous side of things, so right atrium tends to be the most common if you're going to do a single stage cannula. If you need the right atrium completely empty, so if you're going to work on, let's say, the tricuspid valve, or they're going to do a mitral valve repair where they're going to approach it through the right side, then you might want that completely empty, and so you would do a bicable cannulation where they actually cannulate the SVC and the IVC and try to limit any amount of blood returning into the heart during the operation. And then finally, femoral cannulation, usually, again, most of the time done for some other reason you can't get these other sites, or if it's an emergency, just because it's easiest to just cannulate the groin and go on pump. All right, so just a brief word about antegrade and retrograde cardioplegia. So I spoke earlier about, so you've cannulated the patient, now you're going to put them on pump, now you need to actually stop the heart. So you put a cross clamp in between, or you put a cross clamp here, and then you put the antegrade cardioplegia catheter between the clamp and the aortic valve. And when you deliver cardioplegia solution, it's going to go into that area and then go down the coronary vessels and stop the heart. Cardioplegia solutions contain different things, but the main ingredient in it is potassium, so it's going to stop the heart. There are several situations that this won't be enough alone, and you'll have to put a catheter in the coronary sinus to protect the heart. Can you think of any situations where that might be the case, where putting the cardioplegia solution there will not work? Yes, so coronary artery disease, one of the most common. AI, so it's got really bad AI, it's just going to dump right back into the LV. But they can put an LV vent in to try to empty that out, but then it's not going to be protecting and arresting the heart effectively. And the other two, so if they have really bad LVH, the blood flows epicardial to endocardial, so if they have a really thick ventricle, it'll do a really good job of getting sort of that half that's epicardial, but the other half that's endocardial won't do as well. It'll need something coming from the other side. And then the last one is a lima to LED graft. So if they have a lima to LED graft, that's going to be getting systemic blood flow the whole time while you're on pump. And if the cardioplegia solution is going down the LED and it's continually being washed out by the systemic flow going down the lima, then those are people who are notoriously bad cardiac protection. So those are another group of people that you need to put in a coronary sinus catheter. And that's what a coronary sinus catheter looks like. And sometimes we can look on echo and try to help them put that in. Alternatives to that, if you can't get a CS catheter in, or if you're just really old school, you could do just ventricular fibrillation. You could just fibrillate the patient. Hopefully you'll be fast. Or you can circuit rest. Cool the patient and do all those other things that we talked about earlier. All right, so on pump then, now you're on pump. What are the things you're going to be doing? So the perfusionist is going to be monitoring, flow and that kind of thing. You're going to notice that your potassium is probably going to be high because they're going to get cardioplegia. So don't freak out. Potassium is going to be 7 or 8, or maybe even higher. That's okay. You just need to make sure it's back to a normal range before you come off pump. Glucose tends to rise. Current sort of thinking is that you should try to keep the glucose less than 180. The bigger the insult, the worse the hyperglycemia. So circa rest cases, you tend to see more, due to the cooling and due to the insult, you tend to see more hyperglycemia. So just think about that. And then transfusion triggers, tend to try to not transfuse if you don't have to. Have lower thresholds of around 7 or 8 for hemoglobin of coming off pump. Because a lot of times you can get some of the residual volume back. Once you're done, once you're off pump, they can spin down and give you self-saver, or they can actually give you some volume, the residual leftover red cells that they can give you directly, which you can put back in the patient. So often you'll tolerate a borderline or lower hemoglobin coming off as long as you feel confident that you can give it back some other way without having to transfuse allogeneic cells. So rewarming tasks, they say, hey, we're rewarming. Start thinking about what pressors and inotropes you're going to need. Again, a poor LV beforehand oftentimes will not look better when you come off, so be prepared to give an inotrope. Send a Rotem, so that's going to help assess your coagulation status. Make sure you have enough products available and checked. And then rewarming drugs, so some folks will advocate giving some amount of opioids, thinking about post-op pain control. You may give some hydromorphone at that point if you think they're going to extubate relatively soon after you're done. Some attendings will recommend you go ahead and give another little bit of relaxant, because as going on pump sort of dilutes things and causes things. Coming back on pump, you get some weird distributions of medications, and it's really a bad time to the patient to start reaching up off the table. So some folks will say just give a little bit more rock as you're rewarming, and by the time you finish, it'll be gone. You should be able to reverse them when you get to the unit. I won't spend too. I won't keep you here too long. The basic gist of this is you can think about things in sort of two main classes: vasopressors, phenylephrine, norepi, vasopressin. Norepi does have some beta effects at higher dosages, so you may get some inotropic effects as you start to get up to 6, 7, 8 mics a minute. Definitely above 10 mics a minute, you're going to start getting some contractility effects. Vasopressin, so people like vasopressin to some degree because they believe that it spares the pulmonary vasculature, so it'll make your systemic afterload go up without increasing your pulmonary vascular resistance. There's decent evidence for that. Problem with vasopressin is kind of an on-off switch. It's really hard to titrate it. You turn it on, and hopefully it does what you want it to do, and if it doesn't, then you're going to start giving one of the other ones anyway. Inotropes, so epi tends to be one of the more common ones here. The dosage affects the type of receptor that you're hitting, so at lower doses you're getting mainly beta, and the higher the dose you're getting more and more alpha as you increase the dose. We don't tend to use dopamine as much, but it has a sort of similar receptor profile. And then you have other beta agonists, dobutamine, isoprotol. Tend to not use these as much, except I've seen dobutamine and vaso used in combination for heart transplant patients. The idea being the beta vasodilation that you get for the pulmonary vasculature would be advantageous. But you often would have to couple it with something else if you're going to use. You're going to have to couple it with an afterload agent if you're going to give one of these at the bottom. Ionodilators, so Norinone, just a quick word about that. It has a really long half-life. It's a great drug for right heart failure and pulmonary hypertension, but it takes a long time to wear off. And it also has systemic effects. So if you give a bolus of Norinone and you start it, just know that you've bought it. And you've bought it for 5-6 hours. And it works by phosphodiesterase inhibition. I like to ask that mechanism on the test for some reason. Vasodilators, so nitroglycerin, nitroprusside. So nitroglycerin is mainly a venodilator. It's only going to dilate arteries at really, really high doses. Nitroprusside does arteries and veins, but it comes with a theoretical risk of methylhemoglobinemia and cyanide toxicity. So a lot of folks tend to like nicardipine because it's actually a true arterial vasodilator in patients who tend to have arterial hypertension post-bypass. So for patients in the other category, they're not hypotensive but hypertensive. Nicardipine is easily titratable. It works on the side of the vessels that you actually want it to work on, and doesn't inhibit myocardial contractility. So nicardipine is a good choice. All right, other pulmonary vasodilators that you can use. So you can use inhaled nitric oxide, but it's really expensive. And so they have Flolan here. I never remember the dose. That's okay, because they actually have a card attached to the Flolan administrator that tells you the dose. So you calculate your patient's ideal body weight at the top, and then it'll tell you the rate that you're supposed to be putting it in on the pump. The pump looks like this. The pharmacy delivers the flow line in a syringe. If you need help connecting the apparatus to the circuit, your anesthesia tech, your fellow, maybe your attending, maybe I might not be able to because I actually haven't used this one yet. But there's someone who could help you to try to set it up. It is less expensive. And that's why they tend to like using it more than the other. The nice part about these inhaled pulmonary vasodilators is you don't get the systemic hypertension that you would get with giving a lot of morphine. One word of caution, however, if you do give that, if they have severe diastolic dysfunction, that can be a problem. You can imagine if you dilate the pulmonary vasculature and the LV won't relax, they're basically just going to flood the lungs. So if you sit a person in the ICU on Flolan or nitric oxide for days on end, and they have severe diastolic dysfunction, they're going to get pulmonary edema. So just something to think about. All right, and then coming off, so kind of a checklist. You want to make sure they're warm, make sure the electrolytes are corrected, or at least in a reasonable range. If the potassium's still 7, the heart's not going to function very well when you try to come off. And in that case, you just have to wait. Or you can try to give bicarb or some other things to try to lower it. You want to ensure rate and rhythm. So a lot of patients, if they take the cross clamp off, they're going to have weird and funky rhythms, everything from ventricular rhythms, ectopic rhythms. They're going to have heart block, or they may just be asystolic. It's important to note that if you know that their underlying rhythm is asystolic, they're going to put in pacing wires. That's the kind of person that you want to make sure when you're transporting the patient over that you don't rip the wires out, because if you rip the wires out, there's nothing underneath, and that's a problem. So ensure rate, ensure rhythm. Assess contractility, so you can either do that by a TE or you can just look over the drapes. If you look over the drapes, you can actually tell pretty well whether or not the RV is working. Start pressors and inotrodes, which you've already prepared because you've developed a plan. And then make sure the ventilator's back on. Make sure the alarms are back on. They'll start to de-air the patient, so they'll look on the echo, make sure there's no air. Start shaking the patient. Sometimes it just takes time. If there's a lot of air, you can get air down the right coronary, and that can make you have to go back on pump. Or worse, you close the chest, you move the patient over, they have a lot of air sitting in their apex, you move them over, it jostles a lot of air. Now it goes in the right coronary. So now you have to move the patient back on the table, reopen the chest, and that's a mess. So it's good to properly de-air the patient. And then you start waiting for bypass. So you're looking at TE the whole time. Certain places do it differently. Some places the anesthesiologist does it, some places the surgeons do it, some places they kind of do it together. There's not a right or wrong way to do it. As long as people sort of know what the role is and what they should be doing in that time. And then you're going to give protamine. But with Kratz, he just gives all the protamine all at once, which causes a lot of hypotension. Another way to do it would be to give a little bit first, make sure you don't have a protamine reaction, and then work the rest of it in. Usually you announce when a third of it's in, so that the perfusionist can turn off the pump suckers, because you don't want to get protamine too much going in through the pump, because you can clot off the oxygen. In the event that one of those bad things happens, and you have to crash back on the pump. And then after your protamine's all in, you wait 3 minutes, you draw protamine ACT, and you make sure your ACT is back to normal. And then you give the residual volume that the perfusionist is going to hand you. So they usually hand it to you in a bag, and then you just spike it on your volume line and give it. And you've sent a rotem while you're rewarming. Check a rotem. Use that to guide whether or not you need to give any products. You watch for any changes when they close the sternum. And then this last part, make sure your epicardial pacemaker is set back to synchronous mode. So a lot of times at the beginning you just put it on asynchronous because when they bovie it might interfere with the pacemaker. So just make sure it's back in synchronous, because as their heart rhythm returns, you don't want them to get RLT syndrome. It's very rare, but it can happen. So last part, it's the second handout on the back. It's the rotem, which I always have to look at. There's a lot written there, but the two primary ones that you're going to send when you're rewarming are going to be the XTEM and FibTEM. And if you look in the bottom right corner, it kind of describes what they mix the sample with. So for the XTEM, they mix it with tissue factor, and it essentially sort of acts like a PT. It's measuring your extrinsic system. In the FibTim, they give cytocollagen D, which inhibits platelets, and it's supposed to give you, since they're inhibiting platelets, if you still have problems with the way that it looks, that's because you have an inadequate contribution from fibrinogen. That's why it's called a FibTim. So this kind of, in combination, the XTIM and FibTim can help you discern if they're clinically bleeding, what it is that you need to give. So the 3 parameters, if you go to the top left corner, that shows you a waveform, and it gives you the different parameters, the measurements that come out on the screen after you order a rotim. So the CT, the MCF, and the LI30 are the ones to sort of concentrate on. And the CT is the clotting time, and that's just how long it takes for the thing to start to clot. On the XTIM, if the CT XTIM is greater than 80, think factor deficiency. So you don't have to write these down because they're like on laminated cards, like in the OR on the back of the screen. But if the CT is prolonged on the XTIM, greater than 80, then you start having to think about factor deficiency. So you would think about giving fresh frozen plasma. If the MCF is less than 52 on the XTIM, then that actually correlates with low platelets. So that would be a diagram like, if you look on that handout, there's one that says platelet blockers and one that says a hypocoagulable state. So it would be one where the amplitude, the thickness of that waveform is much smaller. So that's kind of a surrogate for platelet function. And then the LI30, the MCF on the FibTim, you would think about giving cryo or fibrinogen. That would be the issue. And then the LI30 is lysis. So if it looks like this waveform here, then that means that the sample is starting to lyse. And then you would basically consider re-administering your Amicar or your TXA. That's it. Questions? Sorry, there's a lot to go over. So, I was trained to give protamine as a test dose and wait 2 minutes. That may be not totally useful because if they're going to have a massive reaction to protamine, it would happen with less than 2 cc's. I mean, it's not like I don't know what that 2 cc's, why that's magical, that's bothering me. So I get the fact that some people don't test dose at all. They don't actually, most of the surgeons will not test dose. They say give protamine. You have Kratz who just boluses it. You got some of the other ones, they give it a little bit slower than that. It depends. So clearly you could give it as a rapid bolus and get away with it most of the time. But I would say ideally you would give it over 5, 7 minutes, something like that. Put it in like a bag and just micro drip it in. Or just give it in little 20, 30 cc segments every 30 seconds or so. Because you do get histamine release and you get hypotension when you give it. So it's just kind of nice to have to fight that. You give it slow enough, you can hype. Thanks. That's my son.